Can I have a show of hands if anybody here does ankle or has done ankle arthroscopy? So, one, two. And people, if you could raise your hands, you aspire to do ankle arthroscopy? Excellent. So, thanks, Ashish. Um, this is the, I don't think you were there yesterday when I was speaking, so let me repeat myself. This is a view of my hospital. The river, that's a Clyde River. This is the hospital. And on this side is a helipad. And when I was coming here, and after seeing Ashish's hospital, I think it looks very similar, only the helipad is missing. So that's maybe coming next. Ankle arthroscopy, I will speak about, before I show the video, I just wanted to briefly speak about it, indications and technique. Indications for ankle arthroscopy, probably the most common one would be ankle impingement. Here's a picture of what an ankle impingement looks like. Schematic picture on the X-ray. So on the X-ray, we are looking at the front of the ankle joint, and this is the spot of impingement where bone is impinging against bone. It's a very common condition, and I will not be surprised if it is, you see these patients routinely. You don't have to do an MRI, but if you do an MRI, then you will see changes, mostly in the front. The other indication for an ankle arthroscopy would be an arthroscopic ankle fusion. And then moving on to smaller print indications will be an osteochondral defect. If you are going to do a microfracture, then you can do that through a scope. Here's an example of a medial osteochondral lesion in the talus. And then if you had a larger osteochondral lesion, then you would do maybe something like a matrix allograft, and you can do that through a scope. And diagnostic, I've just put that there. I don't think I've ever done a diagnostic ankle arthroscopy, because you know the diagnosis before you go in. Ankle impingement, one of the most common conditions would be presenting with deep ankle pain, mostly anterior. As I said, you do an X-ray, you don't have to do an MRI. Technique, in my practice, it is almost always a general anesthetic, but I think anesthetists here would probably prefer a spinal. I'm not sure. I use a thigh tourniquet. I keep the pressure low for 250 as opposed to 300, which is what is routinely used here. It's in a supine position, and I don't use any fancy traction device. So if those who are wanting to start and think that they need ankle traction, I don't think you need one. You feel for the soft spots, which is the portals, medial and lateral, and use a 4 millimeter scope, so that the same diameter as your knee scope. So again, you don't have to have a separate diameter scope for doing an ankle arthroscopy. You can do it with a knee scope. You can do the arthroscopy in all foot and ankle condition areas with a knee scope. So that's subtalar joint arthroscopy, tendoscopy, everything you can do with a knee scope. It is better to have irrigation which is running at power as opposed to just a saline drip which is running on gravity, because some pressure is required. Nick and spread is, you make a small nick in the skin, and you spread soft tissues, and then you enter the joint. So with regards to the technique, I just wanted to highlight the things that are important. One of them is patient positioning. The equipment setup. If you fail to plan, you plan to fail. Portals and the procedure. So in terms of positioning, so here, this is a patient that I have positioned for left ankle arthroscopy. So you can see patient is supine. I'm using a thigh tourniquet. For most foot procedures, I use a tourniquet on the calf, but for the ankle arthroscopy, I prefer one higher up. That's because it allows me to dorsiflex the ankle as and when I have to If I put one on the calf, then I have restriction of ankle dorsiflexion. A view from the side, this patient had previous surgery, his x-rays are up on the screen there. And you can see some scars around his ankle. And the draping, again the draping, the way I do it is like the drape above the knee so that you have your the full access in case you have to harvest any bone graft in osteochondral lesions from the proximal tibia. Then I use this, you can see a bag here. Oops, sorry. There's a bag here. This bag here is a hip dislocation bag. So I don't know if you are using a similar bag when you do a hemiarthroplasty. Then you use, because you want to keep the leg sterile. So this is the same bag that I use to collect the fluid. Instead of using a plastic bag that comes with some drapes for arthroscopy, especially for knees, this bag is much more useful. At the end of the bag, there is a suction tubing attached, so there's no water on the floor at the end of the procedure. And that allows you to bring your next patient in much quicker. And this is the bandage traction I was speaking about, the simple crepe bandage. It goes around the patient and around my waist. In this picture, the bandage is a bit lower just for demonstration purpose, but it will be around the same level as the ankle. So it will sit around my waist. And if I need any traction, I just move my waist. I prefer pelvic motions. So one of my common jokes in these situations is if it's a new scrub nurse and they look surprised that I'm putting a bandage, I say I'm very attached to my patients. I use a small X-ray machine, Mini C. So I need to decide which side the machine is going to come from before I start the procedure, right or left. This is the equipment setup. There's no way I am proposing that it has to be Stryker. It just happens to be Stryker here. But this is a stack that is used for scopy. And I think this bit, so I always ask a new fellow to describe what is what on this stack. And it's like a puzzle, and then send them away. They can't describe all the equipment. So the next time when I see you, I want you to describe it. It's like a game. So there's a hard drive, there's a camera, there's a light source. These would be common in your setup. My understanding, speaking to some of you, is that you probably don't use a fluid management system and probably not using something like a cross flow or a crossfire, which is a burr and a cautery. But I could be wrong. But that is what the setup is. And at the top of it is the monitor. So these are the portals. So that one is the medial portal. This one is the lateral portal. And here I have made my portals. Sorry. Here I have made my portals, and then depending on which side of the ankle it is, if it is the right ankle, if it is the left ankle, and I'm right-handed, I make my lateral portal first, and opposite for the left ankle. So I've made a nick, and I'm spreading soft tissues, and then I pass. This is an artery clip that I pass through to the medial side, in this case, and then I do this. There's a video here. Yeah. And I do, so I keep the ankle dorsiflexed, and then I'm making a channel in the soft tissues so that it's easier for my scope to go in. And this is the traction that I'm applying. By the way, you don't need traction for most cases. Once I'm in, then I used to use the, I use a diathermy wand, arthroscopic wand. So for those who are doing shoulder scopies would be familiar with this instrument, and just clear the soft tissues before going in. And here this is a case of stiff ankle after prolonged immobilization. So there was a lot of soft tissue impingement in this patient. So I've cleared the soft tissues, or I'm clearing the soft tissues, and now I'm on the lateral side. And then that would leave me with the amount of bone to be removed, as we saw in the initial pictures with ankle impingement. So that's the bony impingement. So that is the thing that is blocking ankle dorsiflexion in this patient, which needs to be removed. And there is the burr that's taking away the bone. So if the fluid pressure is not high, then you will end up having no view because of all the bone debris that is being generated. So it needs to be removed from your ankle as with higher pressure. So this is all the bone clearance, and at the end we get a situation where we start like this. So there is the ankle impingement, and this is introp, and then this is the amount of bone roughly that is removed. So it's a lot of bone you have to remove. So don't. One of the problems when you start doing ankle impingement surgery is that you remove very little bone, and the patient's symptoms don't improve. That's a very, very common mistake. You need to remove enough bone so that you have, and it is always useful to use X-ray if you can, to confirm that you have removed adequate bone. I've got another 2 minutes. Shall I quickly go through posterior scopy or? So again, the common indication would be an os trigonum syndrome, which would look like this. Osteochondral defects, not very common because they're mostly in the front half. Sometimes you get a loose body, synovial chondromatosis, tibial nerve impingement, very small print indications, I would say. Os trigonum, I'm sure you would have seen a patient in your clinic, but may not have realized that this is os trigonum syndrome. They usually present with localized posterior ankle pain, usually posteromedial, because it is in line with the flexor hallucis longus. And you can make the diagnosis from an X-ray. You don't need an MRI, but you can do an MRI. And the patient is prone in this case. And you have a medial and a lateral portal, and you're looking for the flexor hallucis longus. And there is bone around the flexor hallucis longus, which you have to remove with a burr. So again, the same burr here is removing that bone to release the pressure from the flexor hallucis longus. It is for people who are runners or who play active sports, you're more likely to see this condition in them. I'm not sure whether you would see them in farmers or other occupations. But you can also see a similar situation if you have somebody with a tongue fracture or a talus fracture in the past. You have to make sure that you have released adequately around the flexor hallucis longus, which is in our view on the right side here. And you get a impingement-free movement situation as we see here. I think I'll stop here in sake of time. Thank you. For?
Would you ever do dry scopy?
I've never done a dry scopy. Why do you have that on my mind?
there's certain fractures where they don't put in a lot of fluid. They just want to see the congruity of the joint. I mean, when you
So,
mix it up with the joint reconstruction or fracture surgery,
yeah.
sometimes
So we call it fractoscopy. So I've done fractoscopy, but not dry because some fluid is
some
needed to
phrases
wash.
managed.
Yeah.
All right. Okay.
I found reaching down the slope for the posterior part is a bit difficult, and then sometimes that part heals very, very slowly. So
That's a
what are your tips?
very good question. Very good question. So I have tried different things. When I started doing arthrodesis, I used to make like patient is supine, but you make a posteromedial or posterolateral portal.
So do you use that kind of the one that we use for tibia nailing, that kind of bar, this kind, where you hang the leg?
I don't use anything special. It's the same. Needs some support under the leg, which is what you're referring to, and also you are worried about damaging the tibial nerve or the sural nerve. So what you do is what you require for that is some angled curettes. That is very essential for it. So you can't do that with a burr, because the burr is straight. So some angled curettes with handles are very useful, and you would need to have them separately because you won't be using it in any other procedure. But there is one or two companies who make these angled curettes for just for the ankle, and Arthrex is one of them. They are on the high expensive side, but they are amazing curettes, like really, really good curettes, as if they are made for the ankle. And once you have those curettes, then you can see right through the Achilles tendon from the front.
Just one last question. What are your tips for the posterior portal when you're doing posterior scopy to avoid nerve injury?
To avoid, sorry?
To avoid nerve injury.
Yeah. So I thought I had a slide on the position, on the, so you have to mark your portals. So once the patient is supine, identify the distal fibula. And then you draw a line which is parallel to the sole of the foot, going around the ankle. And then your portal will be just 2 millimeters medial to that line, which is in line with the first web space. I will find a picture and that will make it easier. But again, in the posterior scopy, your landmark is your FHL tendon, because you do not want to go any medial to the FHL, because there lies your tibial nerve and tibial artery. So with the posterior scope, there is a little bit of faffing about when you are starting. There will be a lot of soft tissue that you have to remove, more than you think, before you start seeing the identifying the landmarks or the anatomy.
Sure. Thank you.
Thank you, One Kalpesh question sir. From me, like in Hageland's deformity, here, Kalpesh, from the chair.
Oh, sorry.
So in Hageland's deformity, how much bone you resect and how you protect the TA?
So with the Hageland's, again, prone position, and before we put the scope in, I try to make the dead space around the Hagelands, almost like stripping away all the soft tissues, right to the end of the insertion of the Achilles. So much so that when you put your scope in, it just goes into the right spot. And then your burr is facing towards the floor, and then you start taking the bone away with your burr. And if you're using a burr, then it kind of gives you an uneven surface. So you have to finish that with a curved osteotome to get a good looking X-ray. So you can remove enough bone with a burr, but when you take an X-ray, it looks like moth-eaten, which even you won't like. So if you want to smoothen it, you have to finish it with a curved osteotome.
Curve osteotome through the portal.
Through the portal, yeah, yeah.
Through the
So 5 or maximum 10 millimeters, 10 millimeters is actually ideal. It will go through your portal, and then you can take bone away with that.
Right. Thank you.
For the tendon is very important because most of the symptomatic patient is having problem with the tendon also. It's the chronic insertional tendinopathy with the TA. So it's not the isolated tendon that is going to create a problem, that is create a symptom for the patient. There is problem with the tendon. That is the main culprit for the symptom of the patient. So what do you do
Correct.
for that?
So you have to take a good history and identify. Not all of them will have symptoms of tendinopathy. Some of them will have symptoms of impingement from the bony Haglands, and you will have to separate those two. So you can separate the two by the tendinopathy pain will be all the time, whereas the bony impingement pain will be mostly with footwear. So if it is bony impingement pain, then I tend to leave the tendinopathy part as it is. So you deal with the bony impingement, and if the patient was to come back with the same amount of pain, then you will have to deal with the tendinopathy part of the pain.
Yeah, thank you. But most of the time, it's always the tendinopathy that leads to the pain to the patient.
So if you, with Haglands, so if you're doing open surgery, then once you have removed the bone and you reattach your Achilles, then you are bringing the insertion of your Achilles more anterior.
More proximal little bit.
So, and more proximal. So it's only 5 or 7 millimeters, but that itself is enough.
Yeah. At the same time, you are debriding the tendon also. You
You're
are taking
debriding
off
the tendon,
at
yes.
the
You're
same
debriding the tendon from inside.
Yeah, yeah.
And when you open it, then it feels very tendinopathic. So
Yeah.
if you're doing open, then debriding the tendon goes with excising the Haglands.
Yeah.
You don't leave it as it is. Yeah.
Yeah. Thank you.
So if there is degeneration in the tendon, should we do arthroscopy for Haglands?
So if the tendon requires debridement, then you're better off with an open procedure. For Haglands, I have now started doing the Zardex procedure. Not all, but some of them, yeah. Because that is also an option, which is difficult to explain to the patient, that you're going to leave the bump as it is, but you're going to break the bone.
Thank you.
Thank you, Kalpesh sir. Next, I would like to call Dr. John Mukhopadhyay sir. His topic is pylon fracture. Has anything